Hi, my name is Regina. Welcome to our medical billing, processing, and payment presentation. During this presentation, you will learn about the requirements for submitting medical bills, how the carrier processes medical bills, and how to resolve disputes over payment of those medical bills, either non-payment or reduced payment of those bills. Before we get started, I would like to tell you that this presentation is for educational purposes only. It provides general information. It does not substitute for the statute and rules. All participants are responsible for knowing and complying with all the applicable sections of the Texas Insurance Code, the Texas Labor Code, and the Texas Administrative Code. Any opinions that you might hear today are strictly personal opinions of the speaker, does not constitute or reflect any statement of policy by Texas Department of Insurance, Division of Workers' Compensation. Getting started, we are going to cover healthcare provider medical billing, the process and requirements, medical documentation. We'll talk about the requirements for submitting medical documentation. We'll also look at insurance carrier processing of those medical bills. We'll look at reimbursement for professional services, and that will be reimbursement for non-network claims specifically, with some exceptions. And then how to resolve disputes if they arise over, again, payments or non-payments of your medical bills. So generally, Chapter 133 applies to network and non-network claims. However, there are some exceptions. Subchapter C, which is medical bill processing and audit by insurance carrier, specifically rule number 133.10, subsection F, relates to medical documentation. Networks can set their own requirements for what requires medical documentation. Also, Rule 133.240, B and I. B is about denying health care for medical necessity retrospectively after it has already been pre-authorized or voluntarily certified. And I is related to reconsideration. Workers' compensation healthcare networks can set their own requirements for requesting reconsideration when your medical bill is denied or reduced. And then subchapter D is specific to dispute resolution of medical bills. Medical fee dispute resolution is different for healthcare networks and non-networks. So we'll look at that also. Let's look at the healthcare provider billing procedures, and that's in Chapter 133, Subchapter B. This does apply to networks and non-network claims. Network claims, healthcare services provided through a workers' compensation healthcare network, are submitted in the same way as they are for non-network claims. First of all, when we talk about who you bill, who does the healthcare provider bill for those healthcare services provided to an injured employee? The first thing we know is that you do not bill the injured employee unless you submit a medical bill to the injured employee that indicates that it is for information only. You are not requesting reimbursement for payment. There are some situations in which you can bill the injured employee, and that is in accordance with 413.042 of the Texas Labor Code, and that is about private claims. Pursuing a private claim, which means billing the injured employee, unless there has been a dispute over compensability or extent of injury, and it's been finally adjudicated by the Division of Workers' Compensation as not compensable or not related to the compensable injury. There are some other exceptions in that statute that you might want to become familiar with. And also Texas Insurance Code 1305.451, and that's relating to the injured employee receiving information about the requirements for seeking health care for their injury through a workers' compensation healthcare network. The injured employee has the responsibility of going to a network provider If the injured employee knowingly goes to a non-network provider without approval from the network, the injured employee can be held responsible for payment of those medical services. Now, that applies only when the injured employee has been notified of the requirement to go to a network provider. So the employer is responsible for letting the injured employee know that they have to seek health care for their work-related injury through a network provider. And the employee is supposed to sign that notification. If the employee never received that notification and goes to a non-network provider, the injured employee is not held responsible for paying those medical bills, only when the injured employee knew about the requirement and went outside the network anyway. And the other thing is when a doctor prescribes medication and the injured employee goes to the pharmacy and has that prescription filled, the injured employee may pay for that on their own and send the prescription and the bill to the insurance carrier for reimbursement for that. So those are some exceptions to billing the injured employee. The law and the rules are written with the expectation that a healthcare provider is going to bill the workers' compensation insurance carrier. The rule actually says submit all medical bills for payment to the insurance carrier except when billing the employer. So you may, as a healthcare provider, you may choose to bill the employer if the employer wants to pay those medical bills. However, during the time in which you're billing the employer, you waive the right to the expectation of being paid promptly. If the employer does not pay you in the expected amount of time, you do not have the right to interest for delayed payment as you would if you were billing the insurance carrier. And then medical dispute resolution. If the employer doesn't pay you what the employer agreed to pay you or doesn't pay you at all, you do not have access to the medical fee dispute resolution process. So those are some considerations when it comes to losing your rights when billing the employer. Now, also, while you are billing the employer during that time, you still must submit a copy of the medical bill to the insurance carrier, just indicating that you are not requesting payment, you are just sending them an FYI copy. The rule requires that. It's 133.20, I believe it is. The rule requires it. Now, sometimes employers don't want you to send the medical bill to the carrier for some reason. You know, maybe they're concerned that their premiums will go up or whatever. But according to this rule, 133.20, a healthcare provider must submit an informational copy of the bill to the insurance carrier. And you should probably also send an explanation that the employer is paying those medical bills. Also, if you are billing the employer, you still have to bill in accordance with the fee guidelines and 133.10, which is relating to required billing forms and formats, which means that you have to use the appropriate billing form and you have to bill using Medicare payment policies. So you still have those responsibilities. So it's important that you think about billing the employer and the implications of that. If you decide to bill the employer, you might consider setting a time frame for the employer to pay you, and if the employer does not pay you, make sure that you have enough time to get your medical bill into the carrier and bill the carrier for those services that the employer did not pay for. So when submitting a medical bill, you must submit the medical bill in the name of the licensed healthcare provider that actually provided the healthcare or that provided direct supervision of an unlicensed individual who provided the healthcare. So if you are a doctor and you are supervising a provider who is not licensed, but maybe a medical assistant or something like that, you can bill for those services under your own name. under the licensed healthcare provider's name. Otherwise, any licensed healthcare provider must submit a medical bill in their own name. Now, also, you must submit a medical bill for an amount that does not exceed your usual and customary charge. You cannot bill for a workers' compensation claim, healthcare services provided to an injured employee, any more or less than you would bill for any other patient. So it's usual and customary charges. You also must use the billing codes from the applicable fee guidelines that are in effect on the date of service. You must also submit your medical bill within 95 days from the date of service. There are some exceptions to timely filing, to those 95 days from the date of service. If you have incorrectly submitted your medical bill to the wrong group health insurance or HMO, maybe the wrong workers' compensation insurance carrier, you didn't know it was a workers' comp claim, the injured employee or the patient did not disclose that to you, you have 95 days from the date you found out that you billed the incorrect carrier to file the medical bill with the correct insurance carrier. The workers' comp insurance carrier sometimes might deny your medical bill for timely filing, that you didn't get it in on time. But you did. You found out you billed the wrong insurance carrier. You sent your medical bill in to the correct workers' comp carrier within 95 days from finding out that you billed the wrong carrier, but the workers' comp carrier denied your bill anyway for timely filing. You must know that your original medical bill had to have been filed within 95 days from the date of service. So the workers' comp carrier isn't denying your medical bill because you didn't get the bill to them within 95 days from the day you found out you were incorrectly billing. They're looking back at when that original medical bill was filed with the incorrect carrier. Now, the healthcare provider and the carrier can agree on another date. Maybe the carrier will say, okay, let's extend this billing time frame for whatever reason. It doesn't hurt to have that discussion with the insurance carrier. There is a definition for a complete medical bill, and you must submit a complete medical bill for the insurance carrier to process it. So the definition of a complete medical bill is when a bill is submitted that meets the requirements of 133.10, which is basically the clean claim rule. It gives you all of the required information and the specific fields that must be populated. That is considered a complete medical bill. The information in those fields may not be correct, but when they are populated, that is a complete medical bill. 133.500 relates to billing electronically. So billing electronically, you go by 133.500, which is really the bill it's really the rule that your clearinghouses are going to use, the people who are submitting those medical bills for you electronically. So it's a complete medical bill if it meets the requirements of 133.10 for paper billing and 133.500 for electronic billing. So documentation. It's important that when documentation is required with a medical bill, you need to send that. It must be sent with the bill. And this, again, applies to non-network claims because networks can determine their own requirements for documentation. So refer to the network for those specific requirements. But documentation is very important because the insurance carrier can only process a medical bill with the documentation that is submitted. They need to know what you're billing for, so you need to get that documentation in. So documentation can be evaluation reports, narrative reports, assessment reports. Any of these type of reports or documentation is considered appropriate documentation. Now, there might be some other kinds of documentation, but generally speaking, this is what serves as medical documentation. And it is very important that the documentation submitted with the medical bill is legible. Sometimes a healthcare provider or doctor may not write real clearly. That's sort of a characteristic. Sometimes. That's a general statement. So you might consider having someone transcribe those notes before it's submitted to the insurance carrier, because if the carrier can't read them, you might as well not send them any documentation. If you're faxing documentation, sometimes it makes it harder to read. If it's faxed several times, it makes it worse. And if it's not legible in the first place, it just could get worse and worse. So make sure it's legible. Make sure it is submitted with the medical bill, but you might have previously provided it to the insurance carrier, so you wouldn't have to submit it with the medical bill. But generally speaking, you're going to submit it with the medical bill. It's real important to know also, and this goes for the providers and the carriers, that when a provider is communicating with an insurance carrier, that the communication has to be clear. It needs to be related to the processing of the medical bill. It needs to be of specific detail, and issues are easily identified. Basically, it's just really good communication so each party understands what the issue is. Now, once you send your medical documentation to the carrier, you've got the documentation attached to the bill, and you send it to the address or the fax number that the carrier has designated, the number to send it to or the address to send it to. And then the carrier receives it, and they may send the medical bill one way and they may send the documentation another way. But bottom line is, once they receive it, once the carrier receives it, then it's considered received by all entities of the carrier. The carrier should be sharing that. Say it goes into the adjuster. It might be that that's the point of contact, the adjuster, and everything flows through the adjuster. So once you send it, if the adjuster sends, something to the bill review folks and the documentation to the utilization review agent, they shouldn't be coming back and asking you for copies of that documentation. And if they do, you are eligible for reimbursement for copies of the documentation. So an insurance carrier may request additional documentation. Say that the documentation they received is missing something, it's not clear, and they need additional documentation that has more detail in it. They can request documentation, and they have to request it no later than the 45th day after they receive the complete medical bill. Now, they're supposed to take final action on a complete medical bill within 45 days or no later than 45 days after they receive the complete medical bill. So if they need additional documentation, they need to ask for it before their deadline. And their deadline does not extend because they asked for additional medical documentation. If they ask for additional medical documentation, you need to send it, because again, they can only make a decision on your medical bill based on the information they have in hand. If they do request additional documentation, it must be in writing. It must include a copy of the medical bill. It needs to be very specific to that bill or the related care. It needs to describe the specific information that they're looking for and that they're, wanting you to send, and why they're asking for it, because it should only be necessary to process the medical bill correctly. So if they're asking for additional documentation, it's a good idea to send it, but they need to tell you exactly, be very specific about what they're looking for and why. And it's also documentation that a provider already has, either in the injured employee's medical record or is getting there, is in the process of being added to the medical record. So once the insurance carrier receives a complete medical bill from a healthcare provider, and I'm going to emphasize a complete medical bill because they don't have to process it if it's not complete. So when the carrier receives a medical bill, they have 30 days to review it to see if it's complete. And if it's not complete, they can either add the missing information that they may have, but they cannot change dates of service or any of the codes, any of the number of units. They cannot change the charges that are being billed. They can complete it with maybe a claim number, maybe an employer address, but they cannot change any of these things. If they do not have the information to complete the medical bill, or they choose not to complete it with the missing information, they can return the bill to the healthcare provider. But they've got 30 days to do that. So once they receive a complete medical bill, it's complete in accordance with 133.10 and 133.500. They have no later than 45 days after the date they receive that complete bill to take final action, which is pay the bill or reduce the amount of payment or deny the medical bill completely. They can also determine or decide that they need to audit the medical bill, continue to audit the medical bill. And that would be for compensability. Maybe the medical bill is the first report of injury that the carrier received, and so they need to investigate that injury. So they may say, okay, we can't pay you, we can't take final action on this bill right now. We're not done with our investigation, so we're going to audit it. If the insurance carrier decides to audit the medical bill, the carrier must pay the provider 85% of the contracted amount, the amount that the carrier and the provider has determined by contract, or the fee guideline amount, the maximum allowable reimbursement in accordance with the DWC fee guidelines. Or for services that are not addressed by DWC fee guidelines, they have to pay 85% of what is considered fair and reasonable reimbursement for that service or services. We've talked about billing for healthcare services. We talked about the insurance carrier processing those medical bills. Now let's look at reimbursement for those healthcare services. Chapter 134 is where the non-network fee guidelines live. Most of Chapter 134 does not apply to network claims, only non-network claims. However, they do apply to designated doctor examinations and required medical examinations. They apply to healthcare services that are provided by an out-of-network healthcare provider that has been approved by the network. If you're an out-of-network healthcare provider, you can only provide services when they are approved by the network. And then pharmaceutical benefits. When it comes to prescription medication, the pharmacy fee guideline applies. The pharmacy fee guideline in Chapter 134 applies to network and non-network claims. Reimbursement for healthcare not provided through a workers' compensation network is reimbursed in accordance with the DWC fee guidelines. A negotiated contract, it may mean a negotiated contract with the network, or if the fee guidelines don't apply, if you cannot find a reimbursement in the fee guideline, or you don't have a contract with the carrier, then reimbursement is based on fair and reasonable amount. Fair and reasonable reimbursement must consist with the labor code. It must ensure that similar procedures provided in similar circumstances receive similar reimbursement. It also must be based on nationally recognized published studies, medical fee disputes, values assigned for services involving similar work and resources, if available, which means that the service that you are providing in the workers' compensation system to an injured employee, reimbursement for that service has to be similar to that same service that is provided in another payer system, in a system that is not workers' compensation. We're looking now at the medical fee guidelines, the division medical fee guidelines. And again, generally speaking, they are for non-network claims. We have the medical fee guideline for professional services, and we also have medical fee guidelines for the workers' compensation specific services. The medical fee guideline for professional services are the kind of services that you would see in any payer system: evaluation and management, physical therapy, occupational therapy, lab pathology and laboratory services. Those are services that you're going to find in any other payer system. And under this fee guideline, a provider is required to use the most current CPT and HCPCS codes that are in effect on the date of service, unless we tell you otherwise in another DWC rule. And specifically, the fee guideline for workers' comp specific services is going to give you those CPT codes. You must use the appropriate Medicare and division modifiers. You must use the appropriate Medicare modifiers because our reimbursement system is based on Medicare reimbursement system. So if Medicare says use a modifier for this service, you have to do it. And if DWC also requires a specific modifier for the service, you have to use that also. So under the medical fee guideline for professional services, you must apply Medicare payment policies. That means for coding and billing, CCI edits, any of the modifiers, as I said. You're also entitled to the HIPSA and PSA bonus payments. Any other payment policies in effect on the date of service, unless there are exceptions that are in DWC rules. And you will find an exception in the reimbursement methodology. Now, because our system is based on Medicare policies, when Medicare changes a policy, it applies to the workers' compensation system also. Now, Medicare may change a policy and apply it to healthcare services that were provided previously, maybe 2 months ago. Well, in workers' comp, for the workers' compensation system, that policy begins on the date that Medicare adopted it and going forward. It is not applied retrospectively to healthcare services that were previously provided, and that's whichever was later. Although our reimbursement system is based on Medicare, there are some exceptions to the Medicare policies. The fact that an injured employee is entitled to all medically necessary health care as and when needed. It's not limited. Medicare does have some services that they do not reimburse. I like to use an example of hearing aids. Medicare has a limited amount of money. They have a budget. They have to determine what they're going to pay for, what they can afford to pay for. So the Medicare recipients aren't necessarily entitled to every kind of medical care. Hearing aids are very expensive because Medicare is limited in budget. Medicare doesn't generally pay for hearing aids, but in the workers' compensation system, if an employee has an injury that affected the employee's hearing, then that employee is entitled to a hearing aid or hearing aids if it is medically necessary to treat that injury, to improve the effects of that injury. So that's a difference in Medicare policy. Another one is the incident to billing. Medicare allows a licensed healthcare provider to bill under another licensed healthcare provider's name. Say a nurse practitioner in Medicare can bill under the supervising physician's name. In our system, the workers' comp system, that can't happen. Any licensed healthcare provider must submit the medical bill for services that they render directly in their own name, under their own name and license number. The other thing, telemedicine or telehealth services. Medicare allows telemedicine and telehealth services, and we allow telemedicine and telehealth services. However, there's a difference. Medicare limits where those telemedicine telehealth services can be rendered. but in the Texas Workers' Compensation System, it doesn't matter where the injured employee is located at the time of the service. So that's a difference in Medicare policy, and this does apply to network and non-network claims. When billing for telemedicine and telehealth services, bill for them in accordance with Chapter 133, submitting a complete medical bill using the appropriate CPT codes. You apply Medicare payment policies, which means that the services that Medicare allows to be conducted through telemedicine or telehealth are the same services that can be reimbursed in the Texas Workers' Compensation System. So it's the same CPT codes. Location doesn't matter, location of the patient doesn't matter, but the CPT codes and the specific services do follow Medicare payment policies. When it comes to calculating reimbursement for the professional medical services under 134.203, which is the medical fee guideline for professional services, and again, this generally applies only to non-network claims. You use the same reimbursement methodology that Medicare uses. Medicare's reimbursement methodology includes a work expense which represents the provider's expertise, time, education, and that sort of thing, and the practice expense, which represents what it costs to run the business, pay the employees, keep the lights on, and then the malpractice expense represents the relative risk involved in that particular service. The GPCI, Geographic Practice Cost Index, represents where the services were provided, and each expense has a corresponding GPCI. We know that healthcare services provided maybe in Dallas would possibly cost more than those same healthcare services provided in another city, maybe in McAllen or in Beaumont, wherever they are. And this also makes it possible for healthcare providers who are providing services out of state can still use this methodology because they're going to have a GPCI that applies also. So you multiply all those expenses by the corresponding GPCI, and then you add that amount together and multiply that amount by a conversion factor, and you get the reimbursement amount. We use the same methodology. Our medical fee guideline for professional services uses the same methodology. However, we replace the Medicare conversion factor with the division conversion factor in that calculation. Now, the division conversion factors are based on the annual changes in the Medicare Economic Index, or the MEI. And the MEI is basically the cost of doing business in the medical world. The cost of living generally increases every year. The cost of services may increase every year, and that's what the MEI represents. Medicare may not change their conversion factor based on the MEI because, again, they have that limited budget and they have to make sure that they have enough money to cover services for all of their claimants. But our conversion factor changes with the MEI annually. This is a representation of how our conversion factors have changed over the years, starting back in 2018, which we really started in 2008, but this just represents the past 2 years. So from 2018, you can see that the conversion factor for most professional services was 58.31, and then it increased in 2019 to 59.19, and for 2020 it's going to be $60.32. That will be the division conversion factor in 2020, and to the right of that table you'll see the increase in the MEI, which is applied to our conversion factor. New conversion factors go into effect on the first of the year. So the 2020 conversion factor will become effective on January 1st next year. So, comparing Medicare reimbursement to reimbursement in the Texas Workers' Compensation System, we're looking at the example is the 99214, which is an established patient office visit, and it's provided in Austin, Texas. And these are 2020 numbers. So you can see that Medicare's methodology is the work expense, which is 1.50 times its GPC, the practice expense, which is 1.45 times the GPC, and then the malpractice expense, which is 0.11 multiplied by its GPC. And again, that GPC represents where that service was provided. So the RVUs represent the service itself, and the GPCs represent where that service is provided. So you complete that calculation, and those RVUs and GPCs, by the way, are available on the Medicare website or through Novitas, the Medicare administrative contractor. So you do that calculation, which comes up to 3.07873. You multiply that number by the conversion factor, and Medicare's conversion factor for 2020 will be 36.09, and Medicare reimbursement will be $111.11 for that service. Looking at reimbursement in workers' compensation, you can see that we use the same calculation, the same RVUs, the same GPCs, results in the same number, and you multiply it by the conversion factor. In this case, it's going to be the conversion factor for 2020, 60.32, and reimbursement for workers' compensation, the same service provided to an injured employee, is 185.71. 2019 workers' comp reimbursement was 164% of the Medicare reimbursement. In 2020, reimbursement is 167% of the Medicare reimbursement amount. Now, there is an easier way to calculate reimbursement. You don't necessarily have to use that long methodology, that long equation. You can simply divide the DWC conversion factor by the Medicare conversion factor and multiply that amount by the Medicare participating amount. Some people call that the allowable, Medicare allowable. And doing that, you get the reimbursement amount for workers' compensation. Now, sometimes this amount, doing this short version, this amount will be a few pennies off of the amount that you come up with if you do the long equation. However, again, it may be just pennies. In this case, it is the same, and that may have a lot to do with how you round your numbers because it could make a difference. Because our reimbursement system uses Medicare policy, you can go to the Medicare website and find those policies and those regulations for a specific type of provider. CMS has a lot of information available on their website. Novitas, again, Novitas Solutions is the Medicare administrative contractor for this area. They also have that information. A lot of it just links over to the CMS website. They do have the Medicare physician fee schedule on their website. It looks a little different than the CMS website. However, it's the same numbers. You can get the same information from them. They'll also have the regulations and guidance that Medicare website would have. So that was the medical fee guideline for professional services, those services that are found in other payer systems or, just general medical services, E&M codes and the like. Now we're going to look at the medical fee guideline for workers' compensation specific services, and these are services that are not generally found in other payer systems. These are services that we need in our system to provide the appropriate health care and to make sure that the injured employee is receiving all their benefits. Some of it even applies to income benefits, but we need to make sure that they are getting what they need. So, as you can see, there are several rules for the medical fee guideline for workers' compensation specific services. And basically, what we had one fee guideline for the workers' compensation specific services. It was 134.204. And that fee guideline had different services. There was a section for each service. What we did was we divided that fee guideline into the separate services. So each specific service that was in 134.204 now has its own rule. Nothing has changed. The reimbursement amount is the same. The coding is the same. It's just divided up. And this is for simplicity. If we have to change reimbursement for a specific service, we can just open up that one rule and change that service without having to open up a whole rule, a big rule with many services in it. So it is for ease of use. Now, this fee guideline, when it comes to workers' comp specific services, generally the fee guideline will give you the description of the service itself, provide the CPT code that you're going to use to bill with. There may be some modifiers that go along with those services, and then generally, again, the reimbursement amounts are actually going to be determined in the fee guideline. So again, quickly, the workers' compensation specific services, the individual rules. One is for the applicability, which gives the effective date of the fee guideline, the payment policies for coding, billing, and reporting. The medical fee guideline for workers' compensation specific services includes home health services. That's reimbursement for licensed home health agencies. Reimbursement is basically 125% of the Medicaid reimbursement amount. Case management services are very important in the workers' compensation system. One of the goals of the Texas workers' compensation system is to provide the injured employee with adequate, high-quality medical care to make sure or to facilitate the injured employee's ability to return to work or stay at work in some capacity. Functional capacity evaluations. This rule will give you the reimbursement amount or the methodology for coding and determining reimbursement for FCEs. And the return to work rehabilitation programs. These are like work hardening, work conditioning, chronic pain management programs. We explain reimbursement for that. We have return to work, evaluation of medical care examinations. This is not a return to work examination where you would complete a 73 and submit it to the carrier. These examinations are examinations that an insurance carrier may request or the division may request. Maybe a designated doctor evaluation or an RME evaluation. That's what this rule applies to. We do have a rule that addresses the work status report, and that is the return to work evaluation that a treating doctor would do, a referral doctor, now even a physician assistant or an advanced practice registered nurse that has been delegated by the doctor. That's reimbursement for the work status report. And that guideline will just tell you to go to Rule 129.5, where the reimbursement amount is actually explained. Designated doctor examinations. Designated doctors have several types of exams that they can conduct. This rule will explain to the designated doctor what billing code it is, what modifiers are necessary, and also which guideline, which rule to go to determine reimbursement for the specific type of service that they are providing, the specific type of examination that they're conducting. One of those types of examinations is an examination to certify maximum medical improvement and assign an impairment rating. So 134.240 tells the DES doc how to bill, what codes to use, but it says for MMI-IR examinations, you go to 134.250 to calculate reimbursement. There are some services that are reimbursable, and we have them in there under miscellaneous reimbursement. It's in Chapter 134. There's a rule that addresses reimbursement for a treating doctor attending a required medical exam, an injured employee that is required to go to an RME can take their treating doctor along, and the treating doctor can be reimbursed for attending. Treating doctors should not be participating. They're not to interfere with the RME's exam, but they can answer questions. If the RME doctor has questions concerning the employee's condition, then the RME doctor can ask the treating doctor questions, but the treating doctor is not to interfere with the RME doctor's exam. Reimbursement for injured employee for travel expenses. If an injured employee has to travel outside a certain mileage, or I think it's like 75 miles, the employee can be reimbursed for that travel, and they would bill the insurance carrier for that travel. Reimbursement for medical documentation. And we talked about medical documentation when we talked about billing. When you are providing the first copy, you're providing medical documentation with your medical bill. There is no reimbursement for that. However, if you are asked for copies of that documentation that you've already provided, you can request reimbursement for those copies. Also, if you are providing the designated doctor with copies of the medical records, you can be reimbursed for those copies. And if OIC, the Office of Injured Employee Counsel, asks for copies of medical documentation, you can also be reimbursed for that. And 134.120 will tell you what that reimbursement is. Also, interest for late payment on medical bills or refunds. If the insurance carrier does not pay you in accordance with the rule in a timely manner, they are supposed to pay you interest on that late payment. You should not have to bill for it. It should be included in your reimbursement. However, if the carrier decides that they paid too much, the carrier can request a refund from the provider. And the provider needs to go ahead and submit that refund to the carrier. If the provider doesn't think that a refund is owed, they can file for medical fee dispute resolution, but get that refund paid back to the carrier timely so that interest is not accruing. Then the fee dispute resolution, they will determine whether or not that refund is actually due. So I said a minute ago that reimbursement for medical records or copies of medical records given to the DES doc are reimbursable. Copies of medical records given to OIC are reimbursable. If an insurance carrier doesn't pay a medical bill by the 60th day after the insurance carrier received the complete medical bill, interest accrues. And then again, healthcare providers that are requested to send a refund to the carrier begins to accrue no later than the 60th day after the date the healthcare provider received the request for refund. So, a provider has billed for the healthcare services provided to the insured employee. The insurance carrier has audited that bill, or they have reviewed that bill, and they have paid that medical bill or have denied the medical bill. The provider may want to request dispute resolution for the carrier's action. So we're looking at chapters 140 through 148 and chapter 133, subchapter D. Chapter 140 and 148 apply to networks also, because that has to do with the actual claim, the compensability or extent of injury. Chapter 133 deals with medical necessity disputes and medical fee disputes. So there is 3 kinds of disputes. The benefit dispute, which is the Chapter 140. Benefits disputes are resolved through benefit proceeding. Those are disputes related to the compensability or extent of injury or liability. Those disputes are resolved here at the central office. There may be some hearings conducted in the field offices, but it's the benefit proceedings that you have to go through to resolve those disputes. Medical necessity disputes are resolved by an independent review organization. Medical necessity disputes and benefit disputes apply both to network and non-network claims. Networks have nothing to do with the claim itself, whether it's compensable or not. It's between the insurance carrier and the injured employee, or the healthcare provider who's provided services to the injured employee and have been denied payment because the carrier says that it's not compensable, the injury is not compensable. Medical necessity has to do with, the healthcare that's being provided. And remember, I said that an injured employee is entitled to all reasonable healthcare services and reasonably required healthcare services to treat that compensable injury as and when needed. So the network has nothing to do with determining the medical necessity. Now, the carrier's utilization review agent does, but medically necessary health care, the injured employee is entitled to that, whether it's a network claim or not. Now, the medical fee disputes are a little different. The medical fee disputes, if it's a network claim, you have to resolve those disputes through the network's complaint process. If it is a medical fee dispute related to a non-network claim, it is resolved by the Division of Workers' Compensation here in Austin. The Medical Fee Dispute Resolution, or MFDR, program area resolves those disputes. So, how do you determine what kind of dispute you should pursue? What's the reason the carrier is denying your bill or reducing your medical bill? The carrier is going to provide that information on the explanation of benefits that is sent to the healthcare provider once they make that determination on that medical bill. And a provider should be getting an EOB. Now, an EOB can come on a form or it can come in, a letter. There's no specific form it needs to be on. However, it has to have the same information that's required. The carrier must use the ANSI CART codes, the American National Standards Institute Claim Adjustment Reason Codes, ANSI CART codes for payment, denial, or reduction of payment. Then they also have to include an explanation of the reason, not just the code, but an explanation of their decision. And that will help you determine which dispute process you need to pursue if that's what you wish to do. Carriers can also use proprietary codes, but they have to be in addition to the ANSI CART codes, and the purpose of those proprietary codes should only be used to help explain, to add some additional information to the reasons that they took the action that they took. So those ANSI CART codes are available on the Washington Publishing Company website. You can just Google Washington Publishing Company and get those codes. Some of those codes don't apply to workers' compensation, but you should be able to determine which do and which do not. Just basically read the code that the carrier provided on the EOB and go to Washington Publishing Company and get an explanation of those codes, which the carrier should be providing anyway, but it may help. This is a reminder that when a healthcare provider and an insurance carrier are communicating, they have to communicate clearly. And when a carrier that is providing an EOB to the healthcare provider, they need to explain it in a manner that the healthcare provider can understand, and vice versa. The healthcare provider needs to explain also what they're doing. So the healthcare provider needs to explain on their medical bill what they're billing for, and the insurance carrier needs to clearly explain to the healthcare provider why they are denying or reducing the medical bill. When it comes to resolving disputes, again, we have 3 types of disputes. The dispute over compensability, extent of injury, and liability, which we call CEL disputes, medical necessity, and medical fee. Now, you have to resolve any issues of compensability, extent of injury, or liability, and any issues of medical necessity prior to filing for a fee dispute. Because if you don't have a claim, if you don't have a compensable injury, and the health care that's being provided is not medically necessary, you don't have a fee dispute. No claim, no fee dispute. Healthcare is not medically necessary. That's a whole different dispute process. You have to determine whether the healthcare is medically necessary before you can pay for it. We're going to review shortly, just a little bit, the dispute resolution process for compensability, extent of injury, or liability. And again, that's chapters 140 through 148. And this applies to network and non-network claims, as I said, because the networks do not determine whether an injury is compensable or not. It's between the insurance carrier and the injured employee and the division. So, CEL disputes are resolved by the hearing section. You request a benefit review conference, which is the first step in resolving a CEL dispute. You send a DWC 45 to the local field office, and for more information about that, you can go to our website. You can select topics A to Z and D for dispute resolution, and it has a lot of information for the injured employee or subclaimants, anybody that's involved in a BRC. It's a lot of good information. When it comes to dispute resolution for medical necessity, either prospectively or concurrently, prospectively is pre-authorization. Concurrent is when the services have been pre-authorized, but you want to extend the length of time that's been pre-authorized. So that's prospective also, before it's provided, before the service is provided. And then retrospectively, for services that didn't require pre-authorization or concurrent review, the insurance carrier's utilization review agent will review that medical bill and the services that are being billed for medical necessity. And we're talking here about Chapter 133, Subchapter D, and also Chapter 19, Subchapter U. That's the utilization review rules that are specific to workers' compensation claims, but Chapter 19 is part of the Texas Department of Insurance Administrative Code. Before workers' compensation became a division of the Texas Department of Insurance, we were involved in writing rules for utilization review for workers' compensation specific services. TDI already had rules for utilization review, but we needed our rules to correspond to those, but there were some exceptions to the regular utilization review rules that needed to be specific for workers' compensation. So basically, Chapter 19 applies to those rules in Subchapter U. Medical necessity disputes are resolved by an independent review organization. To request an independent review, you submit an LHL 009 to the insurance carrier or the carrier's utilization review no later than the 45th calendar day after receipt of a denial of an appeal. An appeal is a reconsideration request. Now you might say, why would I send the request for an IRO to the insurance carrier that has already denied my bill? The fact is that the insurance carrier or the utilization review agent receives that request, but then a process kicks in that actually assigns the IRO. It's not the carrier choosing the IRO, it's TDI's process for assigning an IRO. Now, another thing I want to point out is that this says no later than the 45th calendar day after you receive the denial of the appeal. That means that it is a calendar day, Monday through Sunday. Weekends are counted. If it said working days, that would mean Monday through Friday. Now, there is an exception for holidays. When it comes to working days, there are some exceptions, and that's for holidays. But calendar day is different than a working day. There's more information about the independent review organization process on our website. Again, topics A through Z, and I for independent review organizations. That will tell you how it works. You can get the LHL 009. It'll give you the requirements for requesting dispute resolution through an IRO. So, medical fees. This I mentioned that generally it applies only to non-network claims. There are some situations where it does apply to network claims also. And that's with, for designated doctor evaluations, RME evaluations, or healthcare provided by an out-of-network healthcare provider that has been approved by the network. So, medical fee disputes are resolved by the Medical Fee Dispute Resolution Department here at the main office in Austin. Fee disputes are submitted on DWC 060. That's your request. You send it to MFDR here in Austin, and that's no later than 1 year after the date or dates of service in dispute. Now, if there is a current dispute over compensability, extent of injury or liability, or a dispute over medical necessity, you can send your medical fee dispute resolution request 60 days after you get the result of the CEL or IRO disputes, or even a refund notice. You've got 60 days to file for dispute resolution if you get a refund notice to the insurance carrier. This does apply. So generally speaking, MFDR, medical fee dispute resolution, here at DWC only applies to non-network claims. However, this process also applies to healthcare services provided by a designated doctor or an RME doctor, or by an out-of-network doctor who is providing services with the approval of the network. So, if you have any questions concerning this topic or any other topic, please call us at Comp Connection. If you want to, you can send your question in writing to medben@tdi.texas.gov. You will receive a written answer, a written response to your question. There's a lot of information on our website that may help answer your questions also. The Division of Workers' Compensation has a responsibility for regulating our system, and that includes making sure that participants are abiding by the laws and the rules. And if you feel as though someone, a system participant, is not abiding by the laws and the rules, that they may be in violation, then you can submit a complaint with the Division of Workers' Compensation. Information about filing complaints is on our website. You can also go to topics A through Z and select C for complaints, and that will tell you how to file a complaint, what a complaint is versus a dispute, how to file that complaint, and other information. Also contact information if you have more questions. So that concludes our presentation about medical billing, medical bill processing, and medical reimbursement. Again, contact us please if you have any questions, and we appreciate your time, and we hope that you will join us again.